So the next session will be exciting. So the first speaker is Rotan, my good friend. We flew together in, and we landed 2 hours ago. So, and the title is Targeted Ablation of VT, guided by Waveform Discontinuity.
Well, thank you very much for inviting me back to Prague. I'm very excited to be here. Most importantly, thanks to Hannah Komatova for dealing with me and all the travel. So I'm really grateful to be here. And we're going to talk a little bit about 5 new concepts for VT ablation. These are my disclosures. So where should we ablate in this scar? Well, obviously we're all searching for the isthmus. And if we knew where the isthmus was, then we would know the answer very quickly. But the real question is, can we find the isthmus during sinus rhythm? And if we want to answer that question, well, what does it look like? And in order to really do that, you have to have a lot of VT circuits with a lot of comparison with sinus rhythm propagation to be able to identify it, because that's the holy grail. So the story really starts with us looking at sinus rhythm propagation with extreme high density that really separates the slow zones versus the late zones. And that's very important to emphasize, that slow and late are not always in the same location, because slow only is about conduction velocity and late is a late arrival. So then we started beginning targeted ablation of these slow zones, which we call deceleration zones, as opposed to doing widespread homogenization, which is still the gold standard for VT ablation. So how does this work? Here's a large circumflex inferior lateral scar with a mid-lateral exit, large region to homogenize. But if you flip it, and you flip the script to something that's a functional propagation map, and you look at isochronal late activation with offset annotation, you then can look for regions of isochronal crowding, which tell you that there's local wavefront discontinuity or deceleration. But more importantly, the electrograms have to tell the story. The maps are merely the representation, but we have to be able to appreciate that the electrograms suddenly get wide and low voltage from something that is very narrow and something with large amplitude. And when you focus on areas of wavefront discontinuity like this deceleration zone, and you have the ability to induce VT and map VT for correlation, you see that this is a very nice correlation between a wavefront discontinuity region or decel zone with the entire VT isthmus. And that is a beautiful thing, but you have to be able to see enough VTs to have this correlation. Therefore, you can just ablate a deceleration zone potentially if it's very specific and sensitive and eliminate a VT that you don't have to induce. And that is our obsession with mapping VTs, so we can understand the correlation with sinus rhythm surrogates. When we use these approach, which is quite limited in ablation, less than 30 minutes of ablation, it's less than 20% of the entire scar area, and we're able to achieve success rates of around 60% in non-ischemics and 80% in ischemics, which is in general slightly better than the industry standard. And in general, survival and mortality are quite good with this sort of approach. So this is more of a limited approach that's functionally informed by areas that we believe are the most rhythmogenic with deceleration zones. Now, what creates a deceleration zone? Probably a line of block. And in 50% of the cases, you see a late potential, a split potential, an isoelectric segment that separates 2 populations of electrograms. And that would define a line of block. So this, why do we care about a line of block? Because that's a really nice potential isthmus boundary. But that would tell you that a lot of these isthmus boundaries may be discoverable during sinus rhythm, which means they're fixed. Functional lines of block occur only during tachycardia or with S2, S3 mapping that we're going to hear. It's something that's perturbed. But if it's present during a baseline rhythm, this may be fixed. And my mentor, Mark Josephson, in his last talk, actually said that he believed that the majority of VT isthmus boundaries are functionally determined, which means you cannot discover or localize them during sinus rhythm or a baseline rhythm. That makes VT harder if it's functional. We should all want it to be fixed, because that should make it easier. And if you see a long late potential with an isoelectric segment, you know there's a line of block somewhere in the ventricle, and this is a great candidate for an isthmus. And here would be an example of when you do high resolution mapping of sinus rhythm and you see a U-shaped line of block that is evident during baseline rhythm, and then when you compare it with VT,
a lot of the activation looks almost identical. If I didn't have the label of VT versus sinus, you might not be able to tell the difference. So this is quite beautiful that if you look at sinus rhythm and explore it in extreme density, and you do late offset annotation, you might be able to find the obstacle course that creates VT. Now, how come we haven't been able to find two lateral isthmus boundaries for every single VT circuit? Well, one of the reasons is because it's not always on the surface that we're mapping, because it's a three-dimensional structure. But the other reason might be it's not an optimal wavefront to assess a line of block. If you are assessing CTI block and you do it during high rate atrial pacing, you will not optimally expose your endpoint. You have to pace closer to the line of block. But for decades, we always do sinus rhythm or RV pacing to explore left ventricular lines of block. This doesn't make any sense when you think about differential pacing. The closer you are to the abnormality, the more you're going to expose it. So here would be an example of having abnormal electrograms on a linear catheter, which we're going to try to use tomorrow for a demonstration case, and you don't see a clear split potential, but you know there's late potentials, you know there's something's abnormal, but there's no overt line of block that's seen. We have the luxury of mapping VT, and we see a very small figure of 8 circuit. What if we were able to straddle across the isthmus with a linear catheter? Would you be able to demonstrate both lines of block retrospectively, knowing the VT? Well, let's say we had it across the isthmus and we put it above the isthmus in the upper outer loop, and you pace from this area, you all of a sudden get a wide delay of 105 milliseconds into the isthmus that you know is the isthmus. 105 milliseconds is the amount of time that we define CTI block around the entire right atrium. This is around a 2 millimeter electrode spacing. So it's quite phenomenal to see these degrees of conduction delay whenever we're in the ventricle. It's actually quite remarkable. And what if you were to pace on the lower outer loop portion and pace into the isthmus that you know is the isthmus? Well, that's 102 milliseconds. But the most compelling would be to pace inside the isthmus and see if you get block in both directions during sinus rhythm. And in this case, pacing inside the isthmus blocks in both directions out, which tells you that both of these lateral isthmus boundaries are discoverable during a sinus rhythm. Very important that we invoke differential pacing in VT. And as a matter of fact, when you do differential pacing with the 50% overt lines of block, we can find almost 3 out of 4 lateral isthmus boundaries for VT. So here's an example of a case that we just did last week that really solidifies these concepts. Here's an anterior infarction with a history of a laminated LV thrombus, so we went epicardial as the predominant method first. Extreme dense scar in the anterior wall. We convert it to an isochronal late activation map. We know that the areas of the latest arrival are in the purple and blue, but what you really see here is these electrograms that look late and slightly discontinuous, and actually some electrograms are missing in the middle of it. And if you were to look at wavefront activation discontinuity lines and define them by a large width of electrogram, you could potentially look at this, which would be used on Biosense Webster's CARDO, or with crowding, you would say, these are 2 potential wavefront discontinuity lines. Fine. Could we predict what VTs might happen from these lines of block? Well, the first thing that is a problem for defining a line of block is wavefront convergence. If the wavefronts arrive at the same time, you will not unmask the line of block. And here would be a perfect example of where you have a curvilinear activation, which is not ideal to unmask the line of block. So I want to play this video here of differential pacing to see it in real time. So we have collision, but we're going to pace above, and you see that there is exit going immediately out on the first set of electrodes, but a long stimulus to the lower portion of this tridecapolar catheter. And then if we're going to pace on the lower portion of the tridecapolar catheter, we want to prove that there's bidirectional block. And here you can see it immediately exits the electrograms and the lower portion with a very long delay above. So this is curvilinear activation with collision that is masking a very clear line of block of over 250 milliseconds. So very important to be able to understand that most of the time we're not seeing them because we have suboptimal wavefronts. So here would be an example of that exact pacing in a static image where you're pacing and you're showing there's a bidirectional line of block that typically you would just say is a late potential, and you don't expose a potential lateral isthmus boundary. The other concept is when we do activation mapping, and I hope we can do it tomorrow in a live case, we use the Stevenson model to standardize isochrones. When you do a typical flutter, there is no entrance and exit. When you do mitral isthmus, there's no entrance and exit, but in VT, the exit is what defines the QRS morphology. So it's very reasonable to actually color code the exit. And for that reason, whenever we do the activation mapping during VT, we do onset to onset. That way, purple and white is always the QRS region. And from the purple and white, we work back to blue, light blue, then yellow-green is the 50th percentile, which Stevenson defined as the middle portion of 30 to 70%. So there's a system to the madness of activation mapping, but we're making it as simple as painting by colors with isochrones, with mapping VT. So I want to prep you with that because I'm going to show you a video of how we map VT. Now, one of the pearls of being able to map VT is understanding why sometimes VT is not tolerated. We always believe it's because the ejection fraction is low or the VT is fast. But here would be an example of looking at the sinus rates during VT. We have a whole cardioneural session tomorrow. Why is the sinus rate slow during VT when you have VA dissociation? The patient is dying, and the sinus rates are often unchanged from baseline. Sometimes they increase from the baseline, and sometimes they decrease from baseline. But this would be a very maladaptive response. This would be almost as if it's a vasovagal response, and maybe that is the problem during VT. So when Margarito Pujol Lopez looked at over 250 episodes of VT, she found that 50% of cases are not associated with an appropriate sinus rate response, which may be reflective of maladaptive autonomics. Importantly, we started giving a vagolytic therapy like atropine. And we're doing that with PFA, so why not do it here for VT? And atropine functions like a pressor in 70% of cases and allows us to tolerate VT for mapping. So here would be a case where you have sinus Brady to 47 during rapid VT. The map drops to 38. We cardiovert because it's not tolerated. We give 1 milligram of atropine. Then the map goes to 134 after the cardioversion with atropine. We reinduce the exact same VT, and the sinus rate is 117 during that VT, and the map is 80, allowing it to be tolerated. So a really nice fundamental insight into the physiology of VT that you might get hemodynamic collapse because of a vagal response during VT. What if we were to do cardiac neuroablation to improve the tolerance to VT, decrease syncope, and reduce sudden cardiac death? It's a crazy thought, but I like crazy. So here is an example of mapping during VT. Remember, we're looking for purple and white, and this is a live case during VT. We're looking at the window from onset to onset. We're looking for the areas that are diastolic in real time, and we see purple and white, and blue is the earlier isochrone. So we're able to start finding where the breakout is, and this here is VT1 in that anterior case. The sinus rate was only 660, and that's why we gave atropine to support it. And this was VT1 that we found. Very important, a nice breakout from the light blue to the dark blue, and then the purple and white is the large amount of myocardium that is activated during QRS onset. These are the activation gaps that we see, but we don't see yellow-green here, and this is the reason that you see these population jumps over to the isthmus, and that is discontinuous activation, or VT in 3 dimensions. There's something below the surface that we are not recording during this VT. This is VT number 2 that we mapped of this patient, something that is moving upwards to here, using a different portion of the scar. And you would say, but we had a line of block that you showed me in sinus rhythm. How come the VT can go through the line of block? Well, you must look at the electrograms, because the electrograms show a very nice diastolic corridor, But the area as it approaches the line of block epicardially has no electrogram, and that is an activation gap, or concept number 3. The VT circuit is running away from the surface into the intramural space, and you don't see it because it's going under the line of block. It is not violating or going through, it is going under, and that's why you have no electrogram. So the whole concept of a depth boundary is very important, because lines of block, we think of it in 2 dimensions. But it's important to think about VT in 3 dimensions, that this depth boundary may force the activation on the epicardial surface to go into the intramural area and then resurface when you see it. And the whole point is the electrograms that you don't see. That makes us think that maybe the isthmus is constrained in 3 dimensions. Rather than just thinking that there's 2 lateral boundaries, why are there not boundaries this way, and this way, and it looks like an hourglass in a hyperboloid model? That way, the isthmus is truly constrained in 3 dimensions, and any section that you go through the hyperboloid represents one mapping surface that you're looking at. But we have to understand the true circuit lives as a 3-dimensional animal. So here would be ablation of VT number 3, and this is a 3rd VT we found that was actually now moving downward between these 2 lines of block, and we're about to come on ablation here. We've got 15 grams, but it's epicardial. Ablation comes on, and then we quickly interrupt VT. And those are the 3 VTs. So I want to put it all together because it's really important, and these are the electrograms of the 3 VTs. So if we find a line of block, and it's a 2-dimensional VT, and you ablate on one side or the other side, you might get it as outer loop, and the other side is isthmus, like an incisional flutter. Or if it spins the other way, it'll be outer loop or isthmus reversed. But if it's a 3-dimensional boundary that's forcing depth, and you ablate one side, it might be the exit, it may be the isthmus, and if it reverses, it might be the other way around. So in this case, we had 2 lines of block that we discovered during sinus rhythm. If you had only 5 or 6 lesions to deliver, you might put them on different sides of the line of block. Well, how good would we have been if we never induced any of the 3 VTs? These are the 3 VTs, and they were all using the lines of block as the obstacle course that were the lateral boundaries. So if you were to deliver these lesions there, you might get rid of all of them without even inducing a single VT, which is why the game of VT has changed. Find a line of block and ablate around the line of block, and use differential pacing to expose it. So our evolution of the construct of VT has changed. We're thinking about VT on the Stevenson model on a rotisserie, so it's a 3-dimensional animal. And then we're now engaging into a new randomized controlled trial of 360 patients, looking at deceleration zone ablation around lines of block versus homogenization. And I'm hoping that this will change the way we view VT. It's a non-inferiority study to see if 25 minutes of ablation is as good as 75 minutes or 100 minutes. So hopefully we'll redefine how we're going to be doing VT with fast-fell VT. Thank you very much. Yep. So our next speaker is my travel mate, Pasquale Santangeli from the world-famous Cleveland Clinic. And he's done a lot of great work about septal substrates. And as we know, University of Pennsylvania, with the first Harris-Kakani paper, was teaching about septal disease. And I remember thinking the septum's not relevant, but now every non-ischemic seems to be anteroseptal or septal. And the inferolateral subtypes are less and less frequent. So Pasquale is going to show us a novel pacing method that really looks physiologically at transseptal conduction time.
Thank you, Rod, and thanks for having me here. It's a beautiful city and great conference. So next 15 minutes, we'll discuss about, it's not really a new technique, but it's we revised something that was relatively old for mapping, honestly, and it makes sense. We call it delayed transmural conduction to target septal VTs. The problem that we have with septal VTs is that we all know that these are really the most challenging cases. And the reason why they're challenging is not so much, in my opinion, because of inability to ablate, because typically we know that after multiple ablations, usually the outcomes get better. So that means we're never really in the right spot. And that's why it's an issue of mapping, first of all, because it's not reachable. We can only map like a surface rover, the surface of the endocardium or of the epicardium, and sometimes we really don't see the intramural space. It was data from Paolo Della Bella's lab, and our lab's data look exactly the same. There are a higher rate of mortality, a higher rate of VT recurrences if you have a septal substrate. So how do we identify septal substrates, really? There are different ways to do it pre-procedurally, but none of them is really ideal at the time of the procedure. You can use an MRI as a gold standard to define it. You can integrate the MRI in your mapping system. It's something that still takes time and effort to do that in a proper way. And of course, you can use some other indirect ways, like looking at a 12-lead EKG. Most of the times, you have involvement of conduction systems. You have a long PR or heart block or left banduloid type of morphology. Now, this was the initial paper by the Penn group by Frank Manciolinsky and Harry Sakani was the first one. They really looked at the extent of septal involvement in ischemic cardiomyopathy. 20% of patients did have septal involvement. Right now, at least in our center, we're close to 60% have a septal, some form of intramural component, probably because of the referral base. 29% with intramural abnormalities on the MRI. And typically, these patients present multiple VT morphologies, typically exiting on top of the septum, bottom of the septum. And these are just the breakouts. So we really have no idea where the machinery of the VT is. And for many years, the only tools that we had was voltage mapping. And of course, bipolar voltage is pretty much meaningless in these cases because the bipolar voltage, by definition, is subendocardial with preservation of voltage and therefore will be normal. So for many years, the only way we've been using was really with unipolar voltage to look at something more distant and more far field. Whenever you apply unipolar voltage mapping in a septal substrate, you realize that a large majority of the basal septum, sometimes all the way close to the apex, becomes low voltage. So it's really not ideal to guide where to ablate in terms of the substrate ablation. These are data from animal data from Rod a while back, actually, that I really like this paper. When he looked at unipolar voltage mapping, it's really, because of 3D averaging, it's always like much larger, the area that will light up with unipolar voltage compared to where the actual scar is. So you may end up ablating areas of low unipolar voltage that are not even close to where the scar is located. And this is comparing to direct bipolar recording of different spaces from the endocardium, mid-myocardium, and all the way to the epicardium. So this was the initial study that we've done. That was back in 2000, I believe, 16. Sorry, there is no date there. And basically here, the concept was very simple. So we know that in humans, the transmural conduction, transeptal conduction is about 40 milliseconds in normal. That's why the Comel law, when you have a left-sided pathway and you have ipsilateral bundle branch block, we have to add the time that it gets there, which is about 40 milliseconds, because of transeptal conduction. The idea is that if you do have a scar that is located in the mid-septum, I don't know if you can see my mouse, maybe not, okay, let's see if I can point it up here. If you basically pacing from one side and recording from the opposite side, because of the intramural barrier, the transmural conduction will be longer than 40 milliseconds, and therefore you will see something that is disrupted and prolonged. And these are conduction maps here, pacing from the basal septum on the right side and recording from the opposite side. And we'll talk about later how we actually do this. When you do this type of maneuver, you really want to make sure that the catheter on the right side is not capturing the conduction system. So it's basically, you want to only capture the myocardium. Reason being is because if you capture the conduction system, then it will be invalidated because you will have transeptal conduction via the left bundle branch block, like that. And then in this case, of course, it will invalidate this. But you have a pure myocardial capture, and you have a longer than 40, and usually 40 to 50 milliseconds. The most dramatic ones are more than 60. Typically, you have disrupted conduction because you are recording opposite to an area of dense intramural scar. So with this maneuver, you can at least understand where the dense intramural scar may be located in selected patients. So we studied this in a systematic way. This was already one consecutive patient with non-ischemic cardiomyopathy and septal substrate. And substrate ablation was guided by either activation and entrainment map or ablation of abnormal electrograms, like a standard one. We call it group 1, 57 patients. And it was really not randomized. It was empirical. It was really limited to 2 or 3 operators here, so, which is always complicated because you never know if you're comparing one operator versus another as opposed to a strategy versus another. But in group 2, the ablation was empirically extended to areas of delayed transmural conduction. That means more than 40 to 50 milliseconds when pacing the right base, right paraseptal base, and recording from the left side. And these were 24 patients. Here I'll show you what we do with that. This is a patient here that you see with mid-myocardial scar, normal bipolar voltage, a large area or low unipolar voltage in the basal septum. But here what we're doing, we are pacing from the right base, paraischian area, without capturing the conduction system. And you can see recording with a pentarray on the opposite side that is disrupted conduction with 60 milliseconds delayed transmural conduction. So you know that the recording catheter on the opposite side, which is right underneath the his here, essentially, was located in an area that potentially is adjacent to dense intramural scar. These areas, the areas of delayed conduction, were always located within the area of a low unipolar voltage, but they're significantly smaller. We're usually about 30 to 40% the size of the low unipolar voltage. So it seems to be a little bit more targeted and more specific compared to unipolar voltage map. These are the procedural features. The clinical features were the same. Procedural features were also very similar. And the interesting part is that there was a trend towards an increase in RF time when you extend the ablation to the DCT areas, but it was not statistically significant, probably because of numbers here. But everything else was very similar between the two groups. This is just an example to show you how we actually do this. Here is a patient, a 76-year-old with non-ischemic cardiomyopathy, 30% EF. You see here a reconstruction with a DAS 3D of a dense intramural and septal scar here. And we, of course, always like to induce VT at baseline. Reason being is because you really want to understand if it is a VT with a likely septal breakout or something that is more potentially lateral, that is nothing to do with the septal substrate. And in some cases, MRI can miss areas of substrate that you may not see. So that's why I always like to do at least one induction at baseline to collect a template of the VT. You see this is a classical septal VTs, left bundle morphology, kind of inferior axis, very positive in lead one, so going towards the left shoulder, so exiting from the septum. So we'll talk about VT mapping later. These are data that we're still collecting. But here, that's the way we do, essentially, transmural conduction mapping. This was a patient that we also went epicardial, also because the MRI was not clear, and the only way for me to tell if a patient really has only a septal substrate as opposed to something more diffuse is to map everything, map endocardial and epicardial. So still we do epicardial in some of these cases where it's not clear on imaging where the substrate is located. The epicardial map was completely normal, so here we're pacing from the RV base here, and we are recording. On the opposite side, we also have a multipolar catheter in anterior interventricular vein, because that's the top of the LV septum. And here you can see by pacing, this is the location of the catheter, and recording from up here, there is a very disrupted conduction. In fact, after the pacing spike, you see a far-field activity here from the right ventricle that is followed by a long isoelectric signal, which is probably conduction around the scar here that is intramural, followed by a near-field electrogram here on the left ventricle. And this is the final map that we get. Here you have to adjust depending on where of course, where you're annotating the timing to, what the reference is. But this is the area of large delayed transmural conduction here on the septum in this location. It is just another example, pacing from the RV base. You have the very first electrogram, very blunt, which is activation of the right ventricle. And then you have an isoelectric signal, and then near field activation of the left ventricle. Again, when you see that, you know that there is delayed transmural conduction. So now, the next step, we've been also looking at activation mapping of VT. And typically, these areas of delayed conduction here almost always correlate with so-called what Rod called depth boundary. So here, we always see activation gaps. We have a breakout of this VT in this location. You see the activation here going, which is expected based on the morphology. There is some presystolic activity right around the area of delayed transmural conduction. I'll show you later a side-by-side comparison. And then there is a large activation gap. So these areas do correlate when you can map VTs with areas that are critical for VTs. But we, of course, at least for us, our anesthesiologist is less skilled than what Rod has. We cannot really map VT that often because, unfortunately, the blood pressure drops. And even though we want to try all sorts of mix of medication, they're not comfortable with using them, and that becomes an issue. But this activation of VT here. And here what you see, the comparison between the DCT map and the VT map here. And you can see this area of delayed transmural conduction here. It does correlate with this depth boundary. So the VT here kind of dies in this location, and then it breaks out in the inferior septum as expected from this morphology. So there is a good correlation. Now, how do we target this? In the study, we only targeted the left side. Reason being is because we didn't know if ablating in these areas made any difference in terms of the outcomes. But now this is a recent case done less than probably 6 months ago, where we actually ablate both sides of the septum, because here the idea is that we're targeting something intramural, and therefore you really want to ablate from both sides to reach the intramural scar. Here you see the green lesions, it's kind of like an aerial view, is the right ventricular septal lesions, and the red lesions are opposite to that side. This is just another example here. You can see how interesting this is, because this is a different patient, of course. You have two different VTs. The first VT, they're both inferiorly directed, so based on activation mapping, etc., we targeted right underneath the aortic valve, but there's an area of delayed transmural conduction right underneath the his here that extends all the way to the conduction system. So when you see that, typically we try to stay away from the conduction system, and we'll show data later why we prefer to do that. But if you look at this electrogram, I think it's beautiful. Here you see a sinus beat with completely normal electrograms. When you pace from the opposite side in the same side, all of a sudden you see an area of delayed conduction here with a kind of like a chevron pattern here. So here you see that some of these splines of the pentarray are located close to an area of conduction delay or block that is intramural, and some others are closer here. So you can see the difference. If you just look at sinus rhythm, you will never ablate in that location. And when we look at the outcomes here, it seemed to have a significant improvement in outcomes. Now, this was not randomized, of course, and there was more ablation done in group 1. So again, we need to randomize to really, but this was adjusted for age, sex, LV, ejection fraction, antiarrhythmic drugs, and also results of inducibility test at the end of the procedure. So now, what happens when you ablate there? This is something that I never presented before. We're looking at that. So the idea here is that we're ablating something on the surface to reach something intramural. If that is the case, then most of the times you should see some form of EGM abolition, because we're eliminating the surface of the endocardium, and we're anchoring the lesion to the intramural scar. That's actually what we've been seeing. This is a case where we start ablating an area of delayed transmural conduction. It's kind of modified 4-chamber view here. And I like to use the eyes flipped, and for the case later today, probably I will need to flip it, because otherwise I don't understand it, so I apologize for the audience. But here is the left ventricle. You can see the right ventricle, there is an ICD lead, and this is the lesion on eyes. You see the pre-ablation here. You have a near field, like sharp electrogram with normal voltage. After about 40 seconds of ablation, you have complete abolition. The reason why you see that, this is not seen in normal tissue, is because we're anchoring the lesion to the mid-myocardial scar. 75% of patients see that. So why do we like to preserve the conduction system? Just because when we looked at the data where, in terms of the outcomes, it really didn't make a huge difference, at least for the first procedure. Because here the issue is that the major complication of septal ablation, of course, injury to the conduction system, left bundle branch block or heart block, which is morbid because patients may need CRT upgrades, which we want to avoid if necessary. There was a study that Danielle has done years ago, actually, when we looked at the two different groups, the one that we ablated to injure the conduction system intentionally, and the one that we ablated preserving the conduction system. And as always, more ablation tends to be better, but the results were really not statistically significant. So therefore, at least for the first procedure, for the first session with us, we always try to avoid the conduction system when possible, unless the VT remains inducible and is utilizing the conduction system in that location. So in conclusion, in patients with non-ischemic cardiomyopathy and intramural septal substrate, as an ablation strategy that incorporates the area of delayed transmural conduction with RV basal pacing. And again, when you do that, you want to make sure that you're not capturing the conduction system, just pure myocardium, appears to improve freedom from recurrent VT in this challenging group of patients. All right, thank you for your attention.
Great, we'll save discussion at the end. Our next speaker from the Barcelona group, Andrew Sanchez, the very prolific Barcelona group. He's going to tell us about the latest in deep mapping, decremental evoked potential mapping, and I think we're going to hear that we might need more than an S2.
Well, first of all, I would like to thank the organizers for having me here. It's really hard to follow these two wonderful speakers, so I'll do my best to keep you entertained. I was asked to talk about what has been my focus of research in the last few years, which is deep mapping. And the outline today is, first of all, to describe a little bit an overview of what deep mapping is. And then I'm going to show you different ways of doing deep mapping and what we're working on now, different techniques and outcomes, and also some summary of a project analyzing the data of extra stimulation with two extra stimuli, and hopefully what will come next in our mapping systems. So why are we interested in deep? We heard a lot about electrograms and a lot about lines of block and how beautiful it is depicted during sinus rhythm, but you need something that perturbates the system to initiate ventricular tachycardia. And this is our focus of interest. We want to know what happens in the substrate when you actually perturbate the system by changing the wavefront of activation and also by changing the cycle length of that activation. And it all started by analyzing data from intraoperative mapping, covering with a basket electrode the entire surface of the left ventricle, and looking at the behavior of the late potentials during the initiation of ventricular tachycardia. And we saw, by analyzing that set of patients, that there were a number of late potentials, pre-existing late potentials, that had decremental properties when an extra stimulation was delivered. And in fact, those areas were then more prone to be part of the ventricular tachycardia circuit. As we can see depicted here, the areas with late potentials were much higher than the areas of those late potentials that had decremental properties. And the correlation or the co-localization with the isthmus of the ventricular tachycardia was much higher when looking at only those decremental evoked potentials. This was the initiation of what we call a focused deep approach, and this focused deep approach is delivering extra stimulation in areas where you suspect there is something going on. And that suspicion comes from having identified either late potentials, as we can see here. So in an area where you have late potentials, then you do a S1 and S2 pacing, and you keep track of what happens to the electrogram. So for instance, this one has no decremental properties as compared to this one when you look at it during S1. And another way of doing it is by looking at other surrogates of ventricular arrhythmic substrate. And the group in Leiden, for instance, is using point-by-point mapping catheter and looking at the areas where the bipolar peak-to-peak voltage is below 3 millivolts based on imaging data, and they deliver RV pacing and extra stimulation and check systematically for the appearance of delayed conduction, and they only focus the ablation in that area. So though that technique was, of course, associated with similar sensitivity, because we are looking at areas that have already hints that there is something going on. So there are pre-existing late potentials, but they do increase the specificity for the detection of the mappable VT isthmuses. And also, we were able to see that that was also the case when doing this with current mapping tools in a prospective series of ischemic patients. We also checked that when burning only those areas with decremental properties, we had good outcomes in terms of VT freedom and shock freedom. Several groups have worked along the same line, and this was actually published in the exact same issue of JACC-EP, where the group in Leiden compared data of hidden substrate, so decrement-evoked substrate, versus patients who did not undergo the procedure with such an approach, and matched them by left ventricular function. And they saw that the outcomes after the VT ablation were much better when doing this technique. Also, they extended that to a number of labs in the Netherlands, and they saw that this was reproducible, and you did not need a huge experience to do that on a daily basis. And the results were still good by only ablating those areas with decremental properties. Other groups have worked on perturbating the system by delivering one single RV pacing coupled to the refractory period, close to the refractory period during sinus rhythm, and looking at the area of late activation and burning the area of late activation during sinus rhythm. This comes with higher minutes of RF, but it does have a nice resolution in terms of VT recurrence. One question that we were getting very often was, how close should the S2 be? And this was answered very elegantly by the group led by Tarb Danjal, where they selected a group of patients, 13 patients with mappable VTs that underwent high-density mapping with S1, S2, and at different coupling intervals of the extra stimulation. So 400, close to the refractory period, 30 milliseconds above, like we did in our original paper. And also they did that same map with coupling at the cycle length of the ventricular tachycardia. They analyzed the performance of such type of maps, and it is true that if you go 400 with your S2, your sensitivity and specificity are still good, and probably the number you need to look for in terms of decrement is around 20 to 25 milliseconds, and everything above that gives you a better depiction of what then becomes the VT isthmus. As I said, be careful, this is a very selected group of patients. All of them had one clinical mappable VT, so maybe that's not common practice in our labs very often. Then another group looked at the series of patients and compared late activation mapping versus what you get with the extra stimulation and the location of that late activation during extra stimulation, and compare that to the isthmus of the ventricular tachycardia. And they saw that around 92% of the areas of the isthmus correlated with that late activation as seen with the extra stimulation. Another group reproduced a very similar type of findings, sinus rhythm activation, S1 activation, and extra stimulus activation. And when they put together all the data, they showed that during sinus, which is something that probably we already know from the data shown by Rod before, we only get to the isthmus in 75% of the patients, but if we do RV pacing, that goes higher, and if you do extra stimulus pacing, that area with late activation probably takes you to the isthmus of the VT. Then we said one day with my boss and friend and mentor, Ivo Roca, we said, oh, what if we try and put a little bit more pressure under a little bit more stress into that substrate and do another extra stimulation. And this is how the S3 VT3 project started, and this hopefully will be accepted soon. It's under review. And we included prospectively 43 patients, and 3 of them had focal VTs that were not included, and then 40 entered the protocol. Out of those, 34 could undergo the protocol either with S2 or S3, the majority with S3 pacing, and this is the recipe, so 600 and S2 at VRP plus 30 milliseconds, and S3 at VRP plus 50 milliseconds. This is helpful, and hopefully I can show you the workflow later on during a live case. And if we analyze systematically what happens to the areas of deceleration by looking at those maps, we see that we identified 2 areas of deceleration with S1. This goes to 2.5 areas per patient with S2, and then this goes as high as 3 areas per patient with the extra stimulation. And this is an example where we clearly see those lines of block appearing thanks to the extra stimulation. We also looked at whether they correlated with the areas as detected by CMR and automated processing of the CMR. And we also saw a nice correlation with those areas with the VT isthmus in those patients that we could do high-density pace mapping or ventricular tachycardia activation mapping. Some practical considerations, we'll go over that later on when we are doing the live case. So there is some pre-procedural imaging that we always do in our lab. We then do take some time for merging and having that information in our mapping system at the time of the procedure. The STEAM protocol, I already mentioned that, and then I'll show you later on the mapping window setup. We use OT near-field annotation. We define the target, and then we do a focalized ventricular tachycardia activation map if the patient is clinically stable, and then, of course, very critical, the remapping until the elimination of those areas is achieved. Here's an example of how we set our mapping system. We go to Omnipol, we put the low voltage ID as low as possible. We do standard LAT, The detection is based on near field, so looking at the frequency of the electrogram and annotating that fast frequency component. With that, we've seen that the number of re-annotations that is needed, I hope it's everyone's experience here, is much less. And we need to pay attention to the score of the extra stimulation and also the cycle length. So it's nice to have S2 and S3 at different cycle lengths, so we can then post-process the map and the turbo maps on the go by rerunning those automated annotations. By identifying those areas that we believe are more prone to re-entry, or they have proved to be prone to re-entry, we then, as we see here, can induce VT by having our catheter right there, and very quickly we can identify isthmus, exit, and entry in a few seconds. Then we pace the patient out of the ventricular tachycardia, or we shock the patient out, and this is a nice depiction of the substrate. With that approach, we have seen that 81% of the patients are VT-free at 18 months, and that the results are quite good also for non-ischemic patients. So hopefully we can have an acceptance soon. And for those of you who are lazy, and I know some of you may be, and think that this is very cumbersome, it does take some time to pace the whole ventricle, annotate, tag, look at the areas. Well, there is a project that hopefully will see the light very soon, that is the automation of mapping of dip, so looking at the actual local signal of the S2 and compare the timing with the S1 in real time in the mapping system. And this is a prototype of what is coming on the CARTO, so we will have depiction of the areas of decrement-evoked potentials by color coding, or either by displaying an LAT map with different colors, highlighting the areas where this is happening in real time. This is a swine model that we did in Haifa with the Biosense team, and you will have a window in your CARTO system, and you will be able to display as you want your deep mapping. You just need to click on deep mapping on or deep mapping off when would you want to use it, and then you can overlap it with all whatever map you want to show underneath. Some take-home messages. So the focus dip is highly specific for the VT isthmus, but it does not increase the sensitivity. But the whole substrate dip probably shows you more areas prone to block, and has higher sensitivity and also high specificity for the detection of the isthmus. The S3 mapping is able to identify more deceleration zones than the S2 and the S1 mapping. The automation of the dip will help us all in streamlining the process, and whether a functional guided approach or a conventional approach is better is a question that we don't have an answer for yet. And with that, I would like to thank you for your attention.
Thank you, Andrea. That was a great, excellent talk. I think the next one should be Vivek Reddy. I don't know, is he here?
Paging Dr. Reddy.
Oh, great. Okay. Hi, Vivek.
Excellent.
So
Good.
talking about
You guys
new
hear me
horizons
okay?
in VT ablation.
Hi, can you hear me okay, hopefully?
Yes, yeah.
Okay, excellent. So my charge is to discuss new horizons of VT ablation. I have a number of disclosures, which I'll show here in just a second, and I'll be discussing a number of devices that do not have regulatory approval, so please do note that. I want to cover 3 topics. First, a clinical topic in terms of outcomes of SCAR VT ablation. Then I want to discuss pericardial access, because there is some new technology here. And finally, talk about VT ablation technology. So let's start talking about outcomes. And one of the questions, of course, as we think about how we treat VT is, when along the disease progression do we consider VT ablation? You could consider it early, either at the time of ICD implantation, either as truly prophylactic for patients receiving primary prevention ICDs or secondary prevention ICDs, or patients who have VT ablation after an ICD event, whether it's a shock or shock plus ATP, or patients who have ICD events despite antiarrhythmic drugs. And of course, there are the patients who have this, the extreme, let's say, the patients who have the ICD storm. There are a number of trials that have looked at this, and these are not all perfect categorization, but I think they're reasonably good. SMASH was one of the first that it was really Mark Josephson's brainchild that was published, and where we compared ablation versus control, and all of you know that ICD therapy was reduced with no increase in mortality. There was also the VTAC study that Karl Heinz and his colleagues ran with similar results, reduced VTVF recurrence, and also showed reduction in cardiovascular hospitalization. Then there was the VANISH study, looking sort of the other end of the spectrum, that John Sapp and his colleagues published, showing that that the composite of death, recurrent VT or ICD shock was reduced with ablation compared to escalation of therapy, usually amiodarone. And this was particularly striking in patients who had already received amio as a first approach. Then there were two other trials, SMS in Berlin, which were largely negative studies, I would say, didn't show significant differences, and perhaps that had to do with the technique. It's not really clear. But the more recent trials, and there's 4 of them that I just want to mention, and let's go through these relatively quickly. First is, of course, Partita. All of you know about this. This is a trial that Paolo Della Bella and his colleagues performed, taking patients, following them from the time they received the ICD implant, and at the point that they actually had an ICD event, then they were randomized to either ablation or no ablation. And they saw a significant improvement with ablation, shown here in red, compared to standard therapy in blue, with an NNT of only 3. And in fact, with an NNT of 3.4, there was actually reduced all-cause mortality. There were also reduced VT recurrences with shocks, and importantly, all control patients who had VT recurrences, who experienced a primary endpoint, also had VT recurrences. So Partita was a pretty impressive trial, but it was a very small trial. Are there hints that, yes, you really can have mortality improvements? Well, this is a study that came from the IVTCC that showed that patients who underwent VT ablations and had no recurrence, meaning, let's say, successful VT ablation, fared better in terms of survival than those that didn't. Now, of course, this is not a randomized trial, but it's notable for including a large number of patients. There's also the Survive VT trial, which randomized patients who had a prior MI and presented with VT and randomized them to ablation versus mainly amiodarone. And for the composite endpoint, there was a significant improvement with ablation with a hazard ratio of 0.5. And this was largely driven, there were not significant differences in cardiovascular mortality or appropriate shocks. It was largely driven by this last category of severe treatment-related complications. But those are mostly incessant or slow VT. So I think this is an important trial. There was also the PAUSE SCD trial. I think this is an important trial, notable for including not just post-MI patients, but also dilated cardiomyopathy and ARVC patients. These patients were also randomized to ICD or ICD plus ablation. Importantly, they were relatively split between groups, between the ischemic, non-ischemic, and ARVC population. And for the primary endpoint of VT recurrence, hospitalization, or death, the ablation group did fare much better than the control group, as shown here. But there are 2 important caveats. One is the endpoint was largely driven by VT recurrence, as many of these trials. And number 2, the benefit was really seen in the post-MI and ARVC patients. There was really no difference when you look at the dilated cardiomyopathy patient population. Why might that be? Well, this is one of a number of studies that shows that outcomes of VT ablation in non-ischemic patients is worse than ischemic, and it's probably related in large part to these issues, where you have intramyocardial scar that may not be as amenable to treatment. Finally, I just want to discuss the preventative VT trial. This was just recently presented at ERA. It hasn't been published yet, as far as I know. It's an interesting trial because it was a randomized trial that looked at a very specific population of ischemic patients. These are patients who had infarct-related artery CTO, so chronic total occlusions. Patients who had reduced ejection fraction, planned for an ICD, randomized to either ICD or ICD plus ablation, 4 centers in Slovenia, 60 patients, and here's what they saw. Number 1, you notice that the standard therapy group had a very high event rate of VT or hospitalization for ventricular arrhythmias. And the preventative group had significant improvement with a hazard ratio of 0.3. I think this is a very interesting trial. It's very focused on a very specific population that we probably don't see that often. But I think it was very interesting because it showed that when you pick such a population with a very high event rate, you can see really tremendous improvements. Let's move on to pericardial access. Of course, for many years, many of us have been using this, and the big advance in pericardial access was going to a micropuncture needle. But there are a couple of new approaches. I think we just heard a little bit about this in one of the previous talks, using subselecting a coronary vein, microcatheter puncture into the pericardium with a wire, insufflation with CO2, allowing easy access into the pericardium. I think this is a technique that many of us have used. The question is, did this really introduce a new area in epicardial access, as suggested in the initial publication? I'm not sure it really has, because frankly, while many of us have done it, I'm sure most of you in the audience have done it, the procedure does take a significant amount of time, and frankly, it hasn't really, I think, really caught on, at least in many of our practices. There are other approaches. This is an interesting technique published a couple years ago using a novel blunt tip concealed needle device for epicardial access. The idea was to take this device, sort of as a rotational approach. It has a rotational approach which basically sucks up the pericardium, then you puncture with a needle. It was studied in 11 subjects in a first-in-human trial. It was successful in 10 out of 11. And I think this sounds very promising. But it is notable that it wasn't published in the paper, but in the abstract where this was presented, the mean time for pericardial access was 29 minutes. And that's a considerable amount of time to extend the procedure. I want to show you one other technique. And this actually we're going to show in one of the live cases coming up later today. But I want to just briefly speak to it. This is another device, blunt tool that you go to the pericardium. And the idea is, once you get to the pericardium, you have this tool that grabs the pericardium, retracts, then you advance the needle, and through that advance your guide wire. So very briefly, the idea, let me skip this. The idea is to advance this blunt tunneler to the outside of the pericardium, advance this device called the Rook device, inject some contrast and grab the pericardium, and then as you retract it and puncture with the needle and advance the guide wire. So one interesting aspect about this is that it seems to be relatively quick. Again, early experience, but still, I think, very interesting. And we'll see a case like this later today. Finally, let's talk about VT ablation technology. I think I have about 5 minutes left. So let's go through this. All of you know about bipolar RF ablation. I think the big issue is that it's a bit cumbersome, but it does work as long as the thickness of the tissue is not quite far. It particularly works, by the way, when you use a large footprint RF ablation catheter. All of you know about the lattice tip catheter, and other companies are coming up with similar devices where you emit energy from the whole tip. Compared to a conventional catheter, the big difference is that the thermal footprint is larger. And that matters because, as I show you in this porcine thigh muscle study, when you compare to standard, which is in red, and you look at the lattice tip, this is the difference. On the x-axis is time, and on the y-axis is temperature. If you put thermocouples 3 millimeters in the tissue, there's really no difference between a standard catheter and the large thermal footprint. But the major difference is this. If you look at 7 millimeters underneath the surface, there's a substantial difference. And this difference, that is, you're able to that is, the larger thermal footprint is able to allow more heating deeper in without superheating at 3 millimeters. That's the main difference. By having a larger source of heat, you can project deeper, and it does work. This is from initial experience from 3 centers, 2 in Prague and 1 in Bordeaux. This is a patient with ARVC, one of our cases. You can see this particular VT has an inferior exit. It was exiting from this location. And this patient had prior tricuspid valve surgery, so we couldn't go pericardio. But we ablated from this location to terminate this VT. And for this inferior VT, and here you see the tip, we ablated an inferior, the acute margin to terminate the other VT. The cases were, again, Homolka, ICAM, and in Bordeaux, and there were a total of 12 patients in this initial experience, mostly ischemic, but also ARVC. There's ejection fraction. And what you see is, with reasonable procedure and fluoroscopy times, reasonable number of RF deliveries, we had good procedural endpoints and VT recurrences in a minority of patients. So again, very promising. And the plan was for a large US pivotal trial, though I have to say, I think I made this slide about 2 years ago, so hopefully this will be the year that the trial will actually commence. We'll see. There's, of course, radiotherapy, and I think there's going to be a talk about this later, and all of you know about this. I think alcohol ablation there's a resurgence. I mean, all of us know about injecting alcohol through the artery and using this to ablate scar, but Miguel Valderbano has published some very interesting articles of using not the coronary artery, but the coronary venous system. I think all of you know about this, putting balloons and injecting alcohol in between to get the alcohol basically to pervade into the myocardium to ablate tissue. This is one of our own cases, patient who had a septoscar, no significant scar endocardially on the left side or on the right side, and had multiple VTs coming from this location. So what we ended up doing, here you see RF lesions both on the right side and the left side, and all we could do was slow down the VT. So we end up cannulating, and you can see one balloon here, and there's another balloon over here, and we ultimately instilled alcohol in between the two to ablate these patients' VTs. Miguel has published his data, really impressive data in a single center series. I know he's now doing an NEH study to really look at this in a much more comprehensive, multi-center fashion. Very ambitious project, and I think a very interesting one. I'll also want to just bring up ultra-cool cryoablation. This is a catheter that, through this 8-electrode tip, you can deliver ultra-cool cryo. This is actually a patient who had this sort of syndrome of mid-ventricular obstruction, apical hypertrophy in a hypertrophic cardiomyopathy patient. Here on this ICE image, you see this obliterating left ventricle. This is actually the catheter, and the ice ball is here and causing some shadowing beyond it, and we actually used it to ablate this patient's VT. There is some data, the cryocore data. The initial first-in-human experience was published in JACC EP, I think last year. More recently, Atul presented the data on the cryocure, the 63 patients, and here you actually see the success rate. Again, this is early. One good piece of news is this catheter, I believe, has received CE mark approval, so we should probably see more experience here in Europe. Finally, pulse field ablation. I think this is really exciting for VT ablation. This is a linear point ablation catheter, and what we and others have showed is that you can make lesions, very nice lesions, through scar without being inhibited. When you look at normal tissue versus scar tissue, you can see both on gross pathology and histology, no real differences. So the lesions are very effective, and you can see this also on the MR images. You can also, and this is a very nice image showing bipolar ablation in an animal model, 2 lattice tips on either side, creating really transmural lesions. And here you see an example of a transmural lesion, 16 millimeters thick in an animal model. There's also this concept of modulating the pulse electrical field. This is a catheter from Field Medical. There's some preclinical work showing you can make very large lesions. Now this, I believe, was a monopolar lesion, but again, very large lesions in an animal model, and here you see the histology. One of the interesting aspects about this is the potential for maybe dialing in the dose, making smaller lesions. Let's say you want to go after an outflow tract, PVC, for example, or a sensitive location, versus a large lesion, let's say in a location where you're trying to homogenize scar. And just as a teaser, I just want to show you an image from a recent first-in-human case, literally the first-in-human case, in a patient who had a posterior basal scar, as you see here. And we actually used a PF catheter, this field modulation catheter, went endocardial, delivered lesions. You see these big red balls. And after these lesions, and we don't have the full map here, but basically this whole region was homogenized red. So I think that this is a very interesting concept. Again, very early data, very early experience, but I think very exciting. So this is my last slide. I want to end with, I guess, the slide that I started with, which is when along the disease progression do we consider VT ablation? Certainly, I think we certainly would consider it here in the patients who are having multiple ICD events despite being on antiarrhythmics. The question is, do we consider it earlier? And I think a part of it depends on what is the patient population you're talking about. And the control group will have a very high event rate, including potentially high mortality. Number 2, what is the therapy we're delivering? Is it a simple therapy or is it a complicated therapy? If we can do something very simply where you homogenize the scar, for example, maybe even without even inducing VT, then you can easily consider this being applied very early in the disease state, perhaps over here on the far left. If it's a much more extensive procedure, then perhaps it should be employed further to the right. So I think this is I'm probably more excited now about VT ablation than I ever have, and largely because we have tools now, I think, to answer some of these questions. So with that, I think I'm going to go ahead and stop. Thank you very much.
Excellent. And then for our final session, we're going to have a spirited debate about whether we can predict hemodynamic deterioration during VT ablation. because I think there's so much variation in terms of how MCS or mechanical circulatory support is used. We saw Paulo Della doing a lot of ECMO. Some patients use Impella, some use no Impella. Very wide differences. And whether we can predict who needs it or not, Pasquale will lead with the pro that we can predict hemodynamic deterioration.
All right, thanks again. This will be...
And everyone has 15 minutes.
15 minutes,
right?
great. So my role is to convince you that first of all, hemodynamic compensation happens, and then we can predict it. Of course, not 100%. But before we do this, I actually asked a very unbiased person. So I went directly to our former president and asked him, what do you think about this debate? I don't know if he's going to play. Let's see if there is some audio here. No, there isn't. Can you actually play the audio?
I don't understand what this...
Let me do it again. How do you do it from here?
Honestly, I don't understand.
It's not
what
playing.
This whole debate is about.
All right.
Everyone
Any way we
knows
can
that the
troubleshoot
Pains
this?
D
Otherwise, I'll say what he said.
score
He
is
said
the
I was
best
right.
tool
I can predict it, and okay.
compensation.
So actually,
Also
this
in
was
Prague, I've
okay.
seen it used over.
All right, let me just do this again here.
Honestly, I don't understand what this whole debate is about. Everyone knows that the Pains D score is the best tool to predict decompensation. Also in Prague, I have seen it used over and over again. When I say everyone uses it, I really mean everyone.
That's great. Everyone uses it. So I think, thanks, Barack. I really
Honestly, I
appreciate
don't-
it. I hope you could run again for president, but you can't. So I think there are 5 issues here that we need to talk about when we talk about the compensation. First of all, of course, we all love substrate-based ablation, but it's actually always possible to do a pure substrate-based ablation without any VT induction. That's number 1. Number 2 is that whether periprocedural decompensation happens, and does it even matter if it happens? Can we predict that? That's actually an important issue here, because you can only predict it if you have enough events. If you have a low event rate, you won't be able to find predictors. And the best way of predicting AHD. And this is still something that I'm not convinced about. Even though I'm trying to convince you, I'm not entirely sure that prophylactic mechanical support will prevent AHD and the consequences of AHD. I think we need a randomized study for that. And why not just wait for the compensation to happen, and then we put a mechanical support in? So let's talk about substrate-based ablation first. This is that typical example of patient that get transferred to us, 67-year-old, 15% EF, VT storm, 67 SED shocks. Ablation attempted, aborted because of incessant VT, stabilized with pressors after 3 days, and it was transferred with actually incessant VT, a myojoint intubation and sedation. So in a patient that is actually in incessant VT, you cannot really use substrate-based ablation. So in this case, if you don't put a mechanical support device in, even the patient is not in cardiogenic shock, I'm quite sure you will have decompensation and potentially you will have mortality with that. And this is what we found in this patient. We had like 6 VTs, none of them is hemodynamically stable. VTs kept changing just with manipulation of the catheter in the left ventricle. So in this case, I think it's clear that you need some form of support. So now, these are data from Della Bella's lab, 528 patients undergoing 634 procedures. So how often do you actually see incessant VT or VT storm at the time of the procedure? So 29% in this series presented with electrical storm in the actual case. In those cases, you can do, by definition, substrate-based ablation. And 11% are incessant VT. So again, 11% you will not be able to deal with without hemodynamic support, even if they're clinically stable, because during the procedure with anesthesia, with, of course, changing morphologies of VT with mapping, you won't be able to manage those. And the other aspect that I want to point out here is that just doing the ablation of the substrate may miss about 5% of patients that present with VTs that have nothing to do with the substrate. We found in this series of 690 patients, 5.4% have non-scar-related VTs, most of the times bundle branch reentry, fascicular reentry, or focal VT. So without induction, if you just go for substrate-based ablation in the scar, you won't be able to deal with that. So this was the first study that actually looked at the Pains D score. Here, it was a small series of patients, 193 patients. The primary endpoint was decompensation, which was defined here as a hypotension, less than 80 to 90 millimeters of mercury, with increasing dose of vasopressors, and required either that you stop the procedure early or you have to put some form of bailout support like intra-aortic balloon pump or muscle Impella. And these were the factors that actually were predicted at logistic regression analysis. And here what we looked at, basically we took the odds ratio and we rounded to the next integral level. But you see that most of these variables have really nothing to do with your procedural approach. Pulmonary disease, increased age, ischemic cardiomyopathy, and so forth. The only variable that was really potentially we can change with the procedure use of general anesthesia. And in fact, after this, we've been transitioning more and more to use conscious sedation to no sedation in these patients, which I think is quite important. And the absolute rate of acute decompensation was 11%. Again, these are data from 2015, collected between 2010 and 15. And at that time, I have to be honest, we used to use much more VT induction for mapping. We've been transitioning more and more to less induction when possible, but in some patients, I just showed you that that's not possible. So 11% overall had decompensation, and of course, the risk of decompensation increased with increased tertiles or Payne's D-score, less than 10 points, between 10 and 16, and more than 17 points. That was the highest risk, really, if you use the variable general anesthesia. And when we looked at the episodes of decompensation, 63% actually that did happen during substrate-based ablation. Of course, this patient underwent some form of induction beforehand, maybe predisposed to decompensation. But again, this happened during substrate-based ablation. So, is 11% too high? Are we just seeing some patients that no one else sees? This is actually some data from the Cleveland Clinic from 513 patients with ambulatory heart failure that are just do a right heart cath. And I want to show you here that if you take a patient with ambulatory heart failure with no VT, by definition is more stable than the one with VT. 30%, if you do a right heart cath, has a cardiac index less than 2.2, so near cardiogenic shock. So in these patients, we know that VT on top of it may predispose to that. So it really depends what type of patients you see. But in these patients, if you look at the mortality curves here, the ones that have a cardiac index at baseline less than 2.2, they tend to have high mortality rate, mostly at 10 months, but the curves actually separate very early, between 3 months to 6 months. So really, 11% is not that high, it's actually lower than this group of patients with ambulatory heart failure. So the impact of mortality, when a decompensation happens, mortality increases. There is no question about it. If you look at the Kaplan-Meiers here, the curves separate very, very early here, within the first 3 months here, and then they tend to be parallel. And again, so this basically led us to think if we can prevent decompensation, maybe we can prevent early mortality. Early mortality post-procedure is an issue. It's a manifestation of some form of hemodynamic deterioration during the procedure. We were not always able to capture that, but we look at the VTCC, we have 5% 30-day mortality. Just to give you an example, a procedure of bypass surgery with valve is about 3%. So VT ablation is much higher risk than anything else is done. And the mode of death was about 60% due to heart failure. So something happened during the procedure that wasn't potentially captured that predisposed to early mortality in this group. And the Payne's D-score here was a predictor of mortality. When you see predictor of early mortality, then something happened with the procedure that also predisposed to early mortality post-ablation. Here you see, these are the early mortality between day 0 and day 30, late mortality up to 1 year in the survivors. We also noticed that our old approach, which we don't use any longer, of waiting for the compensation to happen and then rescuing the patient with hemodynamic support is really essentially wrong. Here was a group of patients that had decompensation, and we ended up rescuing them with ECMO at the time of decompensation. And here this is the highest mortality rate you've ever seen in any published paper on VT ablation. 80% died within roughly 10 days to 30 days post-ablation, most of them actually within 10 days from the procedure. The only one that actually survived were the ones that were able to be evaluated for LVAD and transplant. So preemptive mechanical support. This is still something that I'm not entirely convinced about because we don't have a randomized control trial. We tried to apply for it for many years. Industry has not been supportive with that, honestly, so it's been complicated. But the best we had was this propensity match analysis. The problem with this is that the number of Payne's D-score here, because of propensity matching, was way lower than the 17 value that we found in the original paper. That is very high risk. So here the median was about 13, and it was 1-to-1 propensity matched based on a Payne's D-score. And here you see, of course, because we're propensity matching, the two groups were similar, and these are comparing Impella CP, 75 patients, to a control group of 75 patients. And here we found that decompensation did decrease with this approach. It was not zero, it was still about 5 to 7%, because Impella is only an LV support device, and some of these patients have RV dysfunction, which Impella doesn't really help much with. No impact, though, on VT recurrence, but there seemed to be an impact Again, this is not randomized, so again, this is not conclusive. In terms of death and transplant, mostly with early death, again, suggesting that the reduction of decompensation potentially had some benefit. And when we look at the subgroup here, and that's where the number 15 came from, because we didn't have data from more than 17, unfortunately, we have essentially, if you look at the higher risk, more than 15, there is a separation of curves, and lower risk, less than 8, there was no separation. Again, this is still preliminary, because I want to show you here that this approach actually did backfire when we tried at the Cleveland Clinic with the best device we have. This was a group of patients we used the same type of approach when we used the most, I would say, the strongest and most expensive hemodynamic support device available, 5 and 5.5 Impella device in a group of patients undergoing VT ablation. And I'll show you why I think it failed. But here, essentially, you'll see that these patients underwent mostly with Impella 5.5. It's a surgical device. It can provide full hemodynamic support, 5.5 liters here. And you see that these patients underwent slightly more epicardial mapping, so more aggressive potential ablation, you can argue. There are more VTs induced, more VT mapped, and more VT terminated. Procedural time was similar. Decompensation was lower. It was not 0. 34% is a very high-risk group of patients. The pains D-score was about 18 here, the median, I believe. And here, you can see there was a reduction, although not an ablation. So even with the 5 to 5.5 Impella, you still see decompensation in very sick patients. But despite that, we didn't find a difference. And the reason why is for the first line here, because the complication rate that comes with the device. Here, we found a 29% complication rate related to the Impella device placement compared to 2.5%. And complications in sick patients do have an effect on 30-day mortality. I didn't show you the data, but they come from the same paper. But here, if you look at the type of complications, most of them are related to the device implant. And here you have interprocedural ventricular perforation, which is, of course, related to the procedure, but everything else was really related to the surgical access for placing the device, 25%, of course, versus 0. And all of these complications, of course, what happened is that backfired and potentially increased the mortality, is at the end, we ended up with neutral results. There was no impact on VT and VTF recurrence, no impact on mortality. So we actually have been now changing our approach, trying to avoid as much as possible any form of prophylactic support. And of course, in patients with incessant VT and low ejection fraction, high pains D-score, we are compelled to do it. There is no other way of doing those cases. So I'll kind of conclude here that in patients with structural heart disease, a pure substrate-based ablation is not always possible. When it's possible, go for it. Of course, it's the safest approach, and we also do it. Periprocedural decompensation does happen. We know that from heart failure studies. We know that from ambulatory heart failure, but during the procedure. And if that happens, we'll increase the mortality in the short term, and it can be predicted. Of course, in order to predict something, you need to have enough event rates, but the pains D-score so far has been working fine for us to predict early decompensation and early mortality. These are very tightly linked to each other, in my opinion. And waiting for decompensation to occur before starting support is wrong, and prophylactic hemodynamic support may prevent decompensation, although a randomized control trial is really needed. Thank you for your attention.
Great, thank you. And then his competitor will be Predrag Stojadnovich, who has the Contra.
Okay, so good evening, ladies and gentlemen, dear chairman. We've heard a very nice talk from my opponent debater on how PNSD was developed and what's the clinical utility of this score. But my task today is to prove that Obama was wrong. And I think that nobody doubts the importance of catheter ablation in the management of patients with structural heart disease-related ventricular tachycardias. We know that those patients are very sick. They have many comorbidities that increase the risk of peri-procedural complications. And the patients who experience these acute hemodynamic decompensations have a very pure outcome. And as they say that every disagreement should start with some agreement, yes, we agree that patient selection and pre-procedural risk assessment is extremely important. However, the true question is, do we have a right tool for that? And let's take a look on guidelines. What do the guidelines say? We actually have two papers. One is expert consensus from 2019, and the other one are the guidelines from 2022. And really, pain SD score was mentioned in these papers. However, if you carefully read these documents, you cannot find any explicit recommendation that this score should be routinely used in all patients undergoing catheter ablation for this kind of ventricular arrhythmias. And the data I'm about to show you were already presented on the HRS 2023, and we also prepared a manuscript that was recently accepted for publication in the Europace EP. So the reason why I'm telling you that is that our data really underwent a rigorous peer review process. And basically, we analyzed 1,124 patients who underwent their first catheter ablation for structural heart disease related ventricular tachycardias between 2006 and 2020. And we excluded from analysis all patients with implanted mechanical circulatory support. And we performed predominantly substrate-based ablation, mainly under conscious sedation with fentanyl and midazolam. And we had the intracardiac echocardiography in all patients. General anesthesia was used only in patients with epicardial approach or in patients who were on mechanical ventilation because of pre-existing hemodynamical or electrical instability. And over the time, we had 5 to 6 different operators, but they had pretty much the same approach. We performed inducibility testing in all patients at baseline and at the end of the procedure, and decision to go endo or epi was based on the dominant localization of the substrate. So here you see our approach as a schematic representation of what we are doing in ECAM in patients with substrate-based approach. So at baseline, before 3D map was reconstructed, we performed baseline inducibility testing, except for patients who were in incessant VT. So in a case that stable monomorphic VT was induced, we mapped those arrhythmias. We mapped the site of earliest activation in case of focal mechanism, and in case of re-entry mechanism, we performed entrainment or activation mapping in order to define the critical isthmus that was subsequently ablated. However, in the majority of patients, we were able to induce unstable VT or VF that were immediately cardioverted or terminated by overdrive pacing. And in some patients, obviously, VT was non-inducible. So in those patients, we performed so-called substrate mapping during the sinus rhythm. We reconstructed the voltage map. We annotated all abnormal signals, including late potentials, lavas. And we also performed pace map in order to define the exit of the tachycardia and also to detect the zones of slow conduction defined by a long SQRS of more than 40 milliseconds. And the substrate ablation was performed mainly in sinus rhythm. Final inducibility testing was performed not systematically because because of the safety concerns in some patients with fragile hemodynamics. So, and here you see the baseline and procedural characteristics of our study cohort. You see that the majority of our patients were males with mean age of 63 years old, and this is pretty sick population of patients. You see that 31% of patients had an NIHA class 3 and 4, and 25% of our patients had the ejection fraction lower than 25%. And every fourth patient included in this analysis was in electrical storm, and the mean pain SD score was 12. the dominant etiology of the was ischemic cardiomyopathy, and here you see the procedural characteristics. Procedural time in our cohort was around 3 hours, and general anesthesia was used in 15% of patients. So acute heart decompensations occurred in 30 patients, which is 1.2% of the whole study cohort. And we defined acute heart decompensation as intraprocedural or early post-procedural development of acute pulmonary edema or hypotension that required intervention either by drugs, mechanical ventilation, or mechanical circulatory support. And here you see the table in detail of those 13 patients who had decompensation. And you can see that only in one patient we had to implant ECMO in the EP room because of the pulseless electrical activity. And here is a table comparing the groups who experienced acute hemodynamic decompensation and the rest of the population group, and you can see that patients who experienced AHD had a higher NIHA class. They had more strokes in the medical history, and majority of them were in electrical storm, and 1/4 of those patients underwent mechanical circulatory support during the follow-up, but not because of the acute hemodynamic decompensation. And obviously those patients have a very high mortality rate. So I think this is the most important table to look because this is the comparison between our experience and the previously published data. Here you can see that our cohorts are comparable in some characteristics, including early and late mortality. We had a similar PNSD score, but what is obvious here, the difference was in electrical storms. We had fewer patients with electrical storms, and what is the most important is the procedural time, and obviously acute hemodynamic decompensation occurred in, or rates were 10 times lower than previously published, and the procedural time in our cohort was 3 hours, and in UPenn experience was 8 hours. This is a median, and this is interquartile range. So this means that in 75% of patients, procedural time in their experience was more than 6 hours. So this could be also a factor that was not included in the PNSD score that could precipitate to the high acute hemodynamic decompensation rates. In addition, these acute hemodynamic decompensations in our cohort did not accumulate in the upper tercile of the PNSD score. Figure on the left represents the histograms of the patients based on the PNSD score, and you see that patients who experienced this decompensation was accumulating at PNSD score 12 to 14. And this is just a comparison between our and UPenn experience in terms of terciles of the PNSD score. So, and in our cohort, 70% of patients had a PNSD score more than 17. So this means that 191 of our patients should be unnecessarily pre-treated with mechanical circulatory support. And our results are also in lines with other studies. For example, this study from Milano, a group from Milan, they reported hemodynamic decompensations in only 6 of 528 patients, so it's only 1.1%. And also there is another report from the group from Portugal. This was presented only as an abstract, in abstract form, but they also in their cohort, the PNSD score did not predict hemodynamic decompensations, but also did not predict 30 days mortality. In our cohort, PNSD score really predicts the mortality after catheter ablation, but we believe that this score will predict mortality also in general population, and not because of the score, but because of the nature of the factors included in this score that reflects the vital status of the patients. So in conclusion, ladies and gentlemen, in our large cohort of patients with catheter ablation of structural heart disease-related VT, the incidence of acute hemodynamic decompensation events was substantially lower than previously reported. And we believe the main reason for this is the predominantly substrate-based catheter ablation approach under conscious sedation and avoiding the prolonged low cardiac output state. And we believe that in such a scenario, the PAIN-SD score may lead to unnecessary prophylactic use of mechanical circulatory support during the catheter ablation. So overall, our results simply do not recommend the routine use of PAIN-SD score for the prediction of the acute hemodynamic decompensation, and certainly not for the routine use of mechanical circulatory support devices. Thank you for your attention.
I think we'll save the rebuttals for our discussion, which I think is great. One of the important things is you did exclude the ones that had mechanical circulatory support. Was that a small proportion of patients?
It was a small proportion, and the main reason was that the reviewer wants from us to exclude in order to have a clean cohort of patients.
But those are patients that presumably received it maybe in the ICU the day before, or maybe preemptively?
No, these were patients with heart mates and
with
long-term
durable
yes.
LVAD. Oh, I see.
In the majority of cases.
So not a patient that received an Impella maybe the day
Yes.
before or anything like that. Pasquale, do you have any slight rebuttal?
No, I don't. Of course, I mean, I think some of this is related to the approach, and we have changed our approach based on those, our initial data, really. The time we spend mapping is much lower now. The use of general anesthesia is almost very rare, because that was really one of the most important predictors. But looking at your tables, actually the P was significant for PAIN-SD score. If you take the AHD table there, HD versus no HD, and look at the PAIN-SD score, there was 0.05. So I would argue...
Close.
Close. I would argue if you take one more patient, maybe it will be less than that. So what I'm trying to say is that we don't have to throw the baby with the bathwater here. So I think it still has value based on that, exactly that table there. And it's a low event rate, but it's still, there is a, we can call it a significant trend, but 0.05
is not significant.
It's not, you know, but
sorry.
I know it's not. I'm sorry too, because I will have to 0.049, but we're close. What I'm trying to say is that it does predict. And when you see early mortality post-VT ablation, it's always a question of what is causing that. If these patients are dying anyways, or if because something happened during the procedure, they're predisposed to that. And that's my major fear. But I agree with you. I don't use the PAIN-SD alone to decide, because the last study that I showed you was actually a negative study with the Impella 5 and 5.5. So.
Vivek, you were one of the pioneers with Permit and all of the Impella. How has your practice evolved?
Well, actually, very similarly. So we were big sort of users of hemodynamic support devices. We were using them almost pretty routinely in most patients where we're doing scar VT ablation. And then we went back and looked at our data, and frankly, we really couldn't tease out any advantage. In fact, we just saw longer procedure times, and basically when we had enough patients, we did a propensity match analysis, and we published this. We didn't see a big advantage to routine hemodynamic support use. So since then, for probably, I don't know, the past 7 or 8 years, we still use hemodynamic support, but only in selected cases. In fact, the live case you're going to see next is a patient who's a scar VT patient who at baseline is on pressors. So this is an example of a patient who I think it does make sense to use hemodynamic support. But as routine, we basically moved away from that.
Yeah, and it's been hard to get, you know, Abiomed to sponsor this trial because many were using it. But maybe now that there's more restricted, they actually would be interested. As we all know, there's just most recently, there was finally some positive data in the setting of PCI with using Impella. So I still think it's a moving target. But I know ECMO was really a fad for a while, and Dalabella was using it a lot. Do you think we're seeing less of that as well? And you were using ECMO for a period of time
also
as well?
ECMO, it generates more problems than, because after the ablation really flies very well, very easily. But what happens after the decannulation, the physiology is completely different. It's not physiologic. And the cannulating for ECMO alone, you have no LV venting, it's being complicated. So we've been moved away from it, and exactly as Vivek said, we only use it in patients with a very high burden of intraprocedural VT, incessant VT or VT storm with mapping, and the pains D score tends to be very high in these patients and low ejection fraction.
Comments from the audience? I don't want to be the only one asking questions. But I have, yes, sir.
I'm amazed about the impeller use in VT ablation because my idea is that the impeller improves the left ventricular function, but not the right ventricular function. And with these sick patients with definitely pulmonary hypertension, you need the right ventricle, and the impeller will definitely not support the right ventricle. And the pulmonary hypertension is much too high to get a really good benefit out of the impeller for the pulmonary hypertension. So that's what amazes me about impeller and VT ablation.
Yeah, it's a good point. If I can make a comment of that, usually when you put an impeller for a few hours and you recheck the catheterization, the red heart cath, the PA pressure decreases because of the venting of the left ventricle, and that improves the RV function automatically because of reduction of PA pressure. So that's why in some of the cardiogenic shock patients, impeller does work, even though they have biventricular failure in some of them.
I would say in Phoenix, we've used one Impella in the last 3 years.
Yep.
So it's really, there's a lot of practice variation.
I agree.
But agree, a randomized trial might be useful. Vivek, that was an excellent summary on all the evidence. The question we have in general is, do you honestly believe VT ablation reduces mortality?
I think it does. Look, it
And
all
why
depends
haven't we
on the
shown it?
patient population, right? So if you take a patient population that has a low mortality to begin with, your garden variety primary prevention patient, most of who are class 1 or class 2 heart failure status, you're not going to improve mortality unless you follow these patients for 20 years, which nobody will. On the other hand, if you take patients who are, let's say, selected to be a higher event rate, and that selection, I think, is the key, right? How do we select those patients? In Partita, the way Paolo and his colleagues selected was by identifying patients who had a first ICD shock, because then they had a subsequent higher event rate. There may be other ways. Maybe there's something interesting in the ECG or some other machine learning-based approach that will help us identify the high mortality patients. So I don't know. Then the second question is, if there is a mortality benefit, what is the mechanism of that mortality benefit? With AF ablation, AF in heart failure patients, I think it's fairly it's fairly now accepted that it's the amount of AF, the AF burden that seems to worsen mortality, and hence the reason why ablation is beneficial. With VT, I don't think it's likely that it's going to be burden of VT. It could be. It could be that, we all know that ICDs, while they reduce mortality, they don't prevent all VT events. And we know that you can have VT that's not terminable by ICD shocks. But the other issue is that patients who have ventricular arrhythmia, they start a spiral of other things, right? They may receive amiodarone and other membrane active agents, which may worsen heart failure and result in downstream other negative effects. So that would be the mechanism, I would think, where mortality may be reduced.
I think also, as we see with a lot of ablation trials, you would have to prevent crossovers. So the only way I could imagine a VT ablation mortality would be electrical storm with 1,000 patients, but you can't cross someone over, right, from medical therapy to ablation. Because if everyone that gets assigned control or medical therapy then gets crossed over, everyone gets ablation. And then the real question is it even ethical? So that's always the concern that I have as well. And we know what happens with crossovers with Cabana, et cetera, that when people that aren't supposed to get ablation, it really dilutes the intention to treat analysis.
Well, the solution to that is just have more patients. And of course, it's easy to say that. Enrolling a very large trial is very difficult to do.
Right.
But that is the only solution to crossovers.
Any other questions in the audience? My question was for Andrew Porto-Sanchez. Believe it or not, we caught up on time. We have 7 minutes before coffee break, naturally, which is awesome. But Andrew Porto-Sanchez left. I can have my own dialogue with him, but if they're already doing S3, why not just map VT? And how often are they inducing VT? It seems like it's very little, but they're getting such delays. And then the other question I had for him, and maybe you can even answer this because you're the septal guy, if you look at some of the S2s when they're on the septum, they're actually delaying the retrograde Purkinje potential.
Right.
So how do you know you're not just ablating the left posterior fascicle with the S2s? and the
I think
S3s?
they make this point in the paper. I don't want to, of course, defend them because I
Sure.
was not part of the paper. But when you're working on the septum, you do S1, S2, S3, you can have this delayed Purkinje, but you map always in sinus first to make sure that where they are, you know where they are, and you stay away from that because you can have the same type of decremental late potential that are actually Purkinje potentials.
Yeah, just
Can I ask a question to Vivek quickly and probably to, I think you saw the old data from 2015 from Penn, 6-8 hours. That's not what we're doing now. But I think in order to improve mortality, we need a 1 hour, 2 hour procedure, minimal fluid, and we're getting there, I think. So do you think with the new tools, really we will see a huge difference in all this? Maybe we won't see any decompensation at all. We go that to 0%. Potentially, if we do quick mapping and quick ablation, and probably homogenization will be a resurgence of that, because at the end of the day, why not? What do you think?
Yeah, I think two things. I think that VT ablation in scar patients will be two types of procedures. There'll be the one type, which is what I think you're intimating, Pascale, which is a substrate modification approach, where one will use one of these new technologies, which I think will be likely pulse field, but could be something else, where you do mainly a scar homogenization approach without significant induction. And I'm very optimistic with some of the newer tools, as I intimated, you can make really big lesions. In fact, I think the real concern is going to be, are lesions going to be so big, and what are the safety parameters that we put around these procedures so that we don't take out too much normal tissue, because that is going to be something that will be a real problem in the not too distant future. And then I think the other type of VTs are going to be those patients who have the scar homogenization and yet have VT and still have something percolating. I don't think there's going to be very many patients like that because the scar homogenization is going to be quite good, but we will still have some of those patients. And those are the patients where I think doing something like careful mapping with hemodynamic support is going to end up being useful. Because in those patients, doing the other type of substrate approaches, whether it's functional substrate or whatever approach you're going to use, those are going to be exceedingly frustrating because you're not going to see those substrates very easily. So I think that's what's going to happen. And actually, I wasn't very optimistic in my earlier comments about hemodynamic support, but in that latter population, I think hemodynamic support is going to be extremely effective. I mean, one thing that we did show in our early experience with hemodynamic support is that in that population, when you're trying to do careful mapping, it's very effective and it's very safe. So anyway, that's where I think things will end
Vivek,
up.
the field medical adaptation that you showed in the ventricles seemed very encouraging for that first case. We're going to get you to put your nickel down in 2024 in Prague. Is all of the evolution of PFA going to obviate the need for your last part of your talk, which was epicardial access? Are we going to be going to the epicardium 10 years from now?
No,
with all
I
the
think
tools,
the answer is still yes,
Dr.
Rod,
Nakagawa is also in the audience, and I want to ask him the same.
Okay,
Will
let me
we
just
be
answer that
going?
really quick. I think the answer is that it is not obviated. I think we will still go to the epicardium because the reality is, while you can likely in a year or 2 years from now ablate everything from the endocardium, I don't think we'll want to. I mean, if you have epicardial substrate, I don't want to take out 5 millimeters of normal tissue to get to the epicardial substrate if I have a good tool to get to the epicardium safely. And I'm going to show one tool just in the next case, and I think there are others also, other tools that is. I think we're going to be able to get to the epicardium in a very safe way. So I think that the goal is going to be how do you minimize damage to normal tissue and take out the stuff you want to take out.
Yeah, we're going to have Dr. Nakagawa get some of the last words.
Thank you very much. Talking about the PFA easily penetrate the scar, I know there are several published data, but very honest speaking, I'm not convinced. So there are so many factors. Last 4-5 years PFA. I'm talking about tomorrow morning session as well. Still, actually, so many stuff we don't know actually in there. We know that you eliminate potential terminate tachycardia, but unfortunately, it's not good marker for for the dual region formation, and we do need more clinical data, also preclinical data. So at this moment, I'm not convinced.
Yeah,
the
many,
yeah,
many phases of stunning
yeah,
that can happen.
yeah.
Well, I watched Oppenheimer on my 10-hour flight here, and they talked about when you unleash a bomb, it goes on the just and the unjust. And the collateral damage is something concerning when you have weapons of mass destruction. Because if you see, a lot of the strategies for long-standing persistent AFib now, it's almost the entire left atrium is taken out.
Yeah.
And obviously that is a strategy, but I'm not sure that's the best. And we're
Like,
going
yeah.
to see similar for the ventricle.
Like I think 4 years ago, I present data PFA focal ablation, and I'm only guy to say we do need electro tissue contact. And after my lecture, many people, what's wrong, Hiroshi? What's talking about? Are you crazy? Now people, accepting my concept. It took a while, but we'll see. We need more data. Thank you.
5 to 10 grams. All right, well, we're on time. It's exactly 4:30. We did it. Thank you very much.
Yeah, good. Thank you.